So good evening again. I'm sorry for the delay, but I'll make sure we finish on time. So my name is Katile. Let me put my video on. If you can all see me. Can everyone see me?
Yes, you can see you.
Okay, thank you. So we're starting. I hope if I break, you can just tell me. So my name is Katile Mutuku. I am the founder by the Breakers Youth Initiative, and I'll be your speaker today, replacing Bila Joy on the topic on menstruation. So I hope it will be more of discussion because all of us, we are learning, and I hope by the end of the session, we will gain something. So maybe by the show of hands, how many know what is menstruation? You can just use the chat box. How many know what is menstruation? Thank you, Mary. No one else knows what is menstruation. Thank you, Joshua, Lydia, Veronica. Thank you, all of you. So I would like us just to do something that is so short. Maybe in the chat box, you can just type in what you use during menstruation for 1 minute as I share my screen. What do you use? What do girls use during menstruation? Hello, I hope you can all see my screen. So I'm really sorry for that, but we can now start off. So today's our BHNC session 7. We'll be having two topics, menstruation from 7:25 to 8. Then from 8, we'll be having the topic on fibroids by our speaker, Dr. Joy Jagi. He'll say more about himself when he joins. So as I have introduced myself, my name is Katila, founder and director of Barrier Breakers Initiative. So what do you use during menstruation? As you can see, I've seen the chat box that you really know what you use. You can see one, we can use, these are panty. Yeah, you can use panty, you can use, these are tapoons, you can use menstrual cups, you can use sanitary towels. Yeah, you can see we have a lot of things, as I have seen in the chat box that you have written. We can, a lot of stuff. We can use reusable pads. Tapoons are inserted, yes. You can use hot water bottle and pain when you're having cramps. We can use pads. Thank you. Yeah, I see all of us, we know what you can use during menstruation, and that's so nice. So our session today will be talking about the female reproductive, the physiology of the menstrual cycle, understanding the changes that undergo during menstruation period, and maybe an extra goal. By the end of the session, we all expect that we will be able to explain to someone else, those who don't know about menstruation. So how does the female reproductive system look like? This is the anatomy of the female reproductive system. We have the vagina, we have the cervix ear, we have the endometrium or the uterus. This is the uterus, and then we have the endometrium, that is the lining of the uterus. We have this is the oviduct, the fallopian tube. Then we have the ovaries ear. So if we have the inferior view, if you look from down, you can see we have the mons pubis. These are the hair that grow around the reproductive system. We have the clitoris. We have the urethral opening. The urethral opening is almost above just the vagina opening. And then we have the amen, that is mostly broken when someone is a virgin and then they have sex for the first time. Then we have the labia minor. I hope you can all see the labia minor, and then we have the labia majora, this area here, and then we have the anus. This just the same, but now we are having this, I think the sagittal view. This is how it looks inside the body. So what does the menstrual cycle mean? I think we all know that the menstrual cycle, these are the changes that undergo in the female reproductive system every month, and these are the changes that can make you be pregnant. We have a lot of definitions on menstrual cycle, what it is. Yeah, people define it differently, but we all know in every girl every month we have the menstrual cycle. It can be most of the girls, they have 28 days. You can have short periods, you can have long periods, and then for the short periods you can have 10.
Can't hear you, Katila.
Shedding, then that means that is when you will have menstruation. Sorry for that. Okay, so the menstrual cycle, as I said, it's like a cycle, and then it is stimulated by hormones. So we have from the hypothalamus that sends signals. A signal is sent to the hypothalamus, and then it goes to the pituitary. The pituitary will release FSH and LH. These are hormones, follicle stimulating hormone and luteinizing hormone, that will be sent to the ovaries, and then we'll have the ovarian cycle. And then we have release of estrogen and progesterone that change until we have a menstruation, until we have menstruation. That's changing of the endometrium. So the changes are regulated by this axis, hypothalamus to the pituitary, and then we have the ovaries. And then when we reach the ovaries, we'll have the ovarian cycle, we have the hormonal cycle, that is the estrogen and progesterone, then endometrium cycle, that is the shedding. In the ovarian cycle, we know in the ovaries, we have, when a woman is born, they have a lot of follicles. So the follicles will develop. And then when they develop, we'll have the dominant follicle. The dominant follicle, as I can put in easy words, ni follicle yenye may reach maturity. The follicle that has got up to maturity, as you can see, for example, this is a mature corpus luteum. So this one will, the one will get out as an oocyte, and then it will be shed after if fertilization does not occur. So from the ovaries, we have the dominant follicle, this one, it will go, oocyte will be released during ovulation where fertilization can occur. If fertilization doesn't occur, the corpus luteum, it will undergo apoptosis. So in the hormonal cycle, we are now away from the ovary. We have now the hormones. So in the hormonal cycle, we have 3 phases. We have the follicular phase of ovulation, 1 to 3, that takes 1 to 3 weeks, and then we have the luteal phase. As you can see, we say that we start the ovarian cycle, we have the hormonal cycle, and then after this, we'll have now the endometrial cycle. This is how it look. As you can see, the follicular phase will have the dominant ovary, we'll have ovulation, and then we have the luteal phase. So in the hormonal cycle, if I'm fast, you can slow me down kindly. FSH, that is a follicle stimulating hormone, will have the follicle, they will mature. As you can see, we have the mature follicle. And then the estrogen levels, the blue line, they will increase. They reach peak 2 days before ovulation. And then the same time we'll have FSH, it will increase, estrogen, they will increase. And then follicles, they will produce progesterone in the late phase, and they will keep increasing. So if there is increase, as you can see, when the estrogen is increasing, the body temperature is increasing. So you expect during your ovulation, you will have high temperatures, like slightly high temperature. So now, during ovulation, we have massive rise of the LH. As you can see, the green line.
You are breaking too much.
Sorry. You can just stop me when I break. So as I had said, we have the follicle stimulating hormone, we have the estrogen, we have the luteinizing hormone. So in the follicular phase, the estrogen will rise until 2 days before ovulation. During ovulation, the LH will rise, as you can see here. And also the FSH will rise and will have production of progesterone. Now, on the ovulation day, obviously, there will be the massive, which will be the highest level. And it will start to increase 32 to 36 hours before ovulation. And then a peak of FSH will also occur, the red line. So during ovulation, you have 3 hormones which are at their peak. So after ovulation, now we have this corpus luteum. It will have formed and will have progesterone. and estrogen, which were produced during ovulation. So the progesterone levels will keep rising. As you can see, we are on the 14th day. For the next 6 to 8 days after ovulation, we'll have the progesterone rising. And then if there's no pregnancy, our corpus luteum now it will transform itself into corpus albicans, and then the follicular development restarts. But in case there's pregnancy, there's maintained high level of progesterone. And then this is why when you take a pregnancy test using the HCG, you'll see that you have high levels. The high levels which are shown are due to the progesterone. So we are now from the fallopian tube, we are now to the endometrium. In the endometrium, we'll have 3 phases. We'll have menstrual phase, proliferative phase, and we'll have the secretory phase. So the menstrual phase, from day 1 until day 6, I hope you can all see this, day 1 until day 6. This is the endometrium.
Like, kindly share the screen. We can't see your screen.
I am sharing.
Okay.
Can I stop and reshare again?
Yes, yes, please.
Can you see the screen?
Yeah, it is clear now. Thank you.
Okay, I'm sorry. But I hope you are seeing the others.
Yeah.
Okay, sorry for that. Let me just go to there. So so I hope you can all see the screen. I think I have a problem with slide showing. So we were on the endometrium cycle, that is the menstrual cycle, from day 1 until day 6. This is the endometrial cycle, this one. So from day 1 until day 6, we are talking about the menstrual phase. We have the shedding of the endometrium that was prepared for pregnancy. And then we go to the proliferative phase, day 6 and 7, because the estrogen levels produced due to follicular development, now we'll have the endometrium will start growing again, day 6 to 7 of your menstruation. Then it will become thicker, lax, and more vascularized. So the secretory phase. The secretory phase now we are having is where we are having the ovulation. And then there we'll have production of secretory transformation, that is FSH, they will be secreted, LH, and then endometrial secretion will also be released. So implantation mostly occurs between the 19th and 21st day of the cycle because the endometrium is in the best conditions. So you find that most mothers will get pregnant during this time. And if there's no implantation, then we will continue, the endometrium will continue growing, and then we'll have then the menstrual cycle again. So what clinical changes are associated with menstrual? I know we have a lot of changes that we have. Body temperatures rise. We'll have premenstrual syndrome. Premenstrual syndrome is, I think some of us women, we have those mood changes, temperature changes. We can have premenstrual stress, that is premenstrual depression. You can have, a lot of things. Then we have dysmenorrhea. We can have emotional disturbances. We can have, during menstruation, you can have IV bleeding that can lead to anemia. That's why you are told to keep drinking a lot of water. Yeah. So another thing, we can have abnormalities of the cycle. Abnormalities of the cycle, we can have infertility. we can have amenorrhea, we can have irregular cycles, we can have dysfunctional bleeding. Yeah. I'll just go through what are these. So amenorrhea is the absence of menstruation. This can be primary, maybe absence of menstruation since birth, or secondary because absence of menstruation for 3 months. Maybe someone also can be using family planning and then they get absence of menstruation. So it is really important to search the cause of why you are not having your periods. Infertility, same. In infertility, you have to search the cause why you're not having, why you are infertile. So this is characterized by failure to establish a clinical pregnancy after 12 months of regular unprotected sex contact or due to impairment of the person's capacity to reproduce. You know, if you're infertile, maybe you have been having, you cannot get pregnant. In short, you have been having unprotected sex, you cannot get pregnant. That means you are infertile. So you should search for the cause. That's why you should visit a gyna and you have a test to see why you are infertile. Maybe it's the man, maybe it's the female who is infertile. Then, as I said, we have premenstrual syndrome. How many experience premenstrual syndrome?
Hello.
Yes.
Just a comment on back to your slide. The infertility now, according to WHO, they have now actually isolated it that we have the primary and secondary infertility, whereby perhaps you, for example, in primary fertilities, perhaps maybe there is no well-defined reason of infertility. In secondary, you find maybe the lady had given birth normally, the normal pregnancy. However, subsequent pregnancy does not occur, either it's due to miscarriage. So basically also it's defined in terms of age, whereby they're saying ladies under the age of 35, infertility can be defined as a state where unprotected sex intercourse within a period of 12 months. And then ladies of age 35 and above, it can be defined that unprotected sex within 6 months of unprotected sex without any pregnancy. That was just an additional comment.
Thank you so much. I really appreciate that, Edwin. I think we have also learned. Thank you so much for that. Someone is saying I'm too fast. I'm sorry, I talk too fast, but I'll try to slow down. But it's because we're having another session at 8 and we started late. So any other question before I go on? Okay, thank you. So it's menstrual cycle. So thank you so much, Edin, for that clarification on infertility. I really appreciate that. So we'll go to our next our next slide. As I said, we have PMS. I know most of the girls, actually I knew about PMS last year. I didn't know what I'm experiencing. I just thought it was just something that goes on. So in PMS, that is premenstrual, you have these symptoms. Maybe you have increased appetite, you have back pains, you have abdominal pain, you have fatigue, insomnia, you can have sensitive breasts, you feel your breasts are somehow itchy. And I think girls, you understand that. You can have maybe abdominal bloating, you can feel nausea, you can have acne, you can have headache, you can feel constipation. So those are PMS. And actually, some of the girls experience premenstrual syndrome, depression. So if you see someone depressed, maybe you can ask if they are having periods in the next, maybe like 1 week. So, and we have the colors of periods. I thought it was wise if we go through them. I don't know if it is visible. So you can have, the color of the period can be black. So this means it can be either at the beginning or at the end of the period. And maybe it can mean we have a vaginal blockage, but mostly, most of us, we have black period. blood at the end of the periods. Not so black, not tiny black. You can have brown or dark red, maybe the beginning at the end of the period. It can also be an early sign of pregnancy. Maybe it's your last period before you're pregnant. Bright red, that is fresh blood and steady. You know that. You can have pink. Pink can be period blood mixed with cervical fluid, significant weight loss, unhealthy diet. You can be having anemia. So we can have orange, period blood mixed with cervical fluid, maybe a possible infection, mostly orange, just have some doubts. Gray can be bacterial vaginosis. Maybe you can be also having an STI or UTI, but mostly I think STI, gray. Okay. This is just a repeat on it. Mostly these are the colors that you get: bright red, you can have dark red, and then you can have pink. These are just normal most of the time. But in case your period blood is different, just a different color, most likely just see a gyna or just see, a gyna. So maybe sometimes you can have missed periods. Missed period can be because of maybe you're using family planning methods. We have weight changes. You can have a lot of stress. You find that you can have periods before or after the time you expected. Extreme exercise, perimenopause and menopause. Menopause is the time that before now, after 45, most of us, you'll not be having periods after 45 years. So you can be having missed periods. Changes in your cycle, illness, medication, recently started periods, breastfeeding, ectopic pregnancy. I think I'm done. Recap, it is really important to recognize the changes that happen in your body during the different phases of menstrual. We saw we have 3 phases, that is ovarian cycle, hormonal cycle, and endometrial cycle. And then hormonal cycle controls all the changes that happen in the ovaries and the uterus. You see, there's a surge in all the hormones during ovulation, so they will control everything. If after ovulation you'll have fertilization, that means you'll not be having, you're not having menstruation. So some disturbance in hormonal cycle, you can have, if you disturb the hormonal cycle, you will disturb your menstrual cycle. You can lead to amenorrhea, you can lead to infertility. Yeah, and it is important also, as I have said, such the reason why you're not having your periods, such a reason why you're infertile, such a reason, and choose a specialized doctor. And I think that is all. It was just a brief session so that you can have time for questions. So that's all. And I'm sorry if I was first. There will be a speaker will be tackling infertility and any issue to do with amenorrhea, dysmenorrhea on the session on, I think, we'll have a session on infertility. So all the questions on infertility will be answered during that session. So thank you all for your attention. I'll share the attendance form in the next session from 8. So welcome. Talk on endometriosis. We'll have endometriosis session next week on Monday. And we'll have family planning session on Thursday. So all questions on that will be answered during those sessions. Someone is asking, doctors, it is rumored that convincing actually helps with PCOS. I don't know. Lucy, hormonal pills affect the levels of hormone. Actually, what I can say, I know that will be tackled during the session on Thursday, but use of hormonal pills, obviously, it will make your hormonal cycle change. And as we have said, if you change the hormonal cycle, then that means you will change your menstrual cycle, and then it will affect obviously your menstrual cycle. So any other question, or I can ask questions?
I also wanted to add that, can you hear me?
Yes, yes, go on, Edwin.
I also want to add that sometimes due to hormonal changes, normally the 28-day period of menstrual cycle in some women or in some ladies, sometimes it does go up to 35. So the advice is when your period is delayed and there is no chance of clinical pregnancy, always advisable to explain this to your gyna when you visit a gynecology, because sometimes it can be an hormonal issue, or sometimes it can be a medical issue which, when well diagnosed in time, it can be corrected. And then not always that when you are pregnant, perhaps, and you still see that a case of bleeding or menstrual cycle, then also it's good those when you are experience that to always be open and share with your gyna. So gynecological visit clinics are very, very important, and it should not be taken for granted. Thank you for that.
Thank you so much, Edin, for those insights. Thank you. I really appreciate that, Jerry. I don't know. I didn't prepare on safe days because the speaker on infertility will be speaking on that. But maybe we can just have a random discussion on. I know we have different views on the safe days, so I'll just like to have two gents. Gents don't know, but you can have one gent, and then we can have one male, and you can have two female to speak. Maybe what do you think is the safe dates, and how do you count your menstrual cycle? Yeah. Yes, Teresa.
Okay, hello.
Hello.
I hope you can hear me.
Yes.
Yeah, so when we talk of safe and unsafe days, the first day of your menstrual, you start counting your days from the first day you get your menses. So depending on how long, whether it's 3 days, whether it's 5 days, whether it's 7 days, depending on the days you will experience your periods. So you start counting. Let's take, for example, for someone who maybe menstruates for like 5 days. So you start counting from day 1, day 2, day 3, 4, and 5. So after day 5, from then sasa see this person menses zake zitakuwa zimeisha. So you count, you continue counting day 6, 7, 8, starting from day 9 or day 7, starting from, depending, day 7, day 8 through day 15 or 14. Those are unsafe days. Because that's the period mostly where you'll be experiencing your ovulation. And then after day 15, mpaka sasa the next time you'll be experiencing your menses, because your menses, your cycle takes around 28 days. Normal cycle is 28 days, but 28 to 35 days, that is okay. So from day 15 to the next time you'll be having your menses, we consider that safe days. So that's how you put safe days and unsafe days. Yes.
Thank you, Teresa. Maybe one male can give their insights. I know we all know this. Which day do you think your friends, your sisters have safe days?
Let me share.
Yes, Ross.
Yeah, as you know, all females are not the same. We have some with cycles of 28 days, others 21 days, others even 18 days. So the one with the 28 days is the one now you can be sure of the of the safe days and unsafe days. But this one of 19 or 18 days is very difficult to predict because of the less days this person is taking. I can give my own example. when I was still pushing, there was I was using natural and I was counting the days. You know, mine was at times 18, at times 19, at times 21. I've never seen the one of 28. So I'm busy counting, and I had even known the dry days, as somebody has said, or the safe days. But you'll find that during those safe days is when I conceived. So when I tried to find out why it happened, then I was told it's because of the short cycle. So I say, ladies, we are not the same. So one to count well, the one who can do it well is the one of 28 days, but less than that is a problem. Thank you.
Thank you, Rose, for that. Because of time, let me just maybe make a conclusion. I think, as you have said,
can I make some comment before you come in?
Yes.
This is an area I'm really interested on. So sorry for, you have done a fantastic presentation, but allow me to make a comment that this area is very important on safe days. One thing you have to understand, ladies and gentlemen, is that the spermatozoa takes around 24 to 72 hours within the system. And once an egg is released, it normally takes between 12 to 24 hours. So the significance of this is that you always count your days, and I agree with the presenter who said during her safe days, that's the time she got pregnant. So that's the time you realize to you it was a safe day, but you didn't capture that when you have an intercourse and there is an ejaculation, therefore the spermatozoa will have many hours within the system. So normally you count 6 days before or 7 days after, simply to take care of the sperms in the system. So for ladies, you be very careful that once you release an egg is released, then 12 to 24 hours, the egg will still be in the system. And when you have an intercourse, either before the release of eggs, let's say 3 days before, then if you release an egg, the sperms, chances are very high, the sperms will still be in the system, and chances are very high fertilization gonna take place in the fallopian tube. Thank you.
Well, Edin, that was a very important point to note. Actually, I was to say something on the same. As you have said, let me just go back to my presentation a little bit. We have said if you cause any change in the hormonal cycle, then we'll have a change in your menstrual cycle. And as you know, all of us, for example, for me, if I change my environment, obviously my menstrual cycle changes automatically. So if you have anything that will change, maybe your monocycle or your environment, as you said, you can have missed periods because of different issues. So anything that can alter your cycle, then that means maybe you are expecting to ovulate on a certain day, but you ovulate maybe before or after. Some people argue that we have the first 14 days are constant. Others argue the first 14 days are not constant. But for me, I usually say I don't literally believe on the safe days because I don't know the changes that I've undergone on my hormonal cycle. So maybe it's a point of debate, but we are not the same. Every person behaves differently. And you know, as Edina said, the sperm stays in the system, the female system, like for 3 days. So maybe you can have sex like someday, like 3 days before, and then that was the time you're having ovulation, and then you become pregnant. Or you think that ovulation has already occurred, but you forget that you had sex like 3 days before. So the sperm is still viable, and then you still get pregnant. So I think to as much as we rely on safe days, but we don't know the changes that undergoing, mostly the hormonal changes and maybe environment changes. Yeah. So thank you so much, Edin, for that insight. Maybe I can see in the chat box. Someone is saying, yeah, we say, yeah, thank you, Lucy. Family planning methods, anxiety, medical condition can change it can cause hormonal imbalances. What else? we have this group of female who menstruate after 2 to 3 months and they've never been on in any family planning. It's normal. Obviously, if you're having a period cycle for 35 days, that means you'll have a long period. And sometimes you can have any hormonal challenge. Let's say we have some things that will cause you to have missed periods. So if you're having missed period, that means you can have, maybe sometimes you can stay for long periods or short periods. You can actually have menstruation for 2 months, some of girls, others for long. So you should go and check. If it's not complicated, there's no problem. But if you think it's a complication, you can go and see your doctor. So any other question? I'm just seeing if our next speaker has joined. Is Dr. Joy in? Okay, I can't see him in, but once he joins, we'll go to the next session on fibroids. But honestly, we'll have a session on family planning. We'll have a session on infertility, and the speakers will elaborate more on the menstruation cycle and changes that might occur that you have not touched. So prepare your questions for that. Any other questions? So if you don't have a question, I'll just ask, what do women use to know their menstrual cycle? Maybe you can write in the chat box, what do we use to know a menstrual cycle? Apart from the memory, what do we use? Mobile apps, thank you. Any other things that you use? Apart from menstrual apps, you have the calendars. What else do you use? Do you know about the menstrual beads? The black beads, the 28 black beads that mostly for the young girls who don't know to keep track of the calendars. But most of us, we use the mobile apps to check on our periods. Thank you. And then maybe the last question I can have, what are the myths and misconceptions that we have about the menstrual cups? I know most of us don't like using menstrual cups or the tampons. Maybe you can chat in the chat box, and then we'll have a debate at the end of the session. What are some of the myths and misconceptions we have about menstrual cups and the use of tampons during our menstrual cycles? You can keep chatting in the chat box. And then with that, I think we are over with the menstrual cycle. If you have any question, you can still ask in the chat box and in the feedback form, and kindly fill the sentence form. So with that, I hope we have learned a lot or something little about menstruation, and we'll continue talking more about menstruation and maybe, debates on menstruation. So with that, I think I just saw a speaker joined in. So we'll just go to our next session on fibroids and have your questions ready. And we hope you will learn from our speaker, Dr. Joy Jagi. I think he just joined. Welcome so much, Dr.
Yeah, thank you very much. I'm not sure if I could use the video here on. So I believe, okay, all right, sorry, yes. So good evening, everyone. It is Kathleen?
Yes.
How are you doing?
I'm fine.
Very good. And good evening to everyone who's joining this evening. Yeah, my name is Joe Njagi. I'm a gynecologist. And first of all, I really want to thank the organizers of this session for having me on board, just to share a little bit of my experience during my practice, and more so in terms of fibroids. Get to see a lot of fibroids a lot during our practice. So this is something I think I would say a lot of us gynecologists are kind of familiar with. And I'm hoping that by the end of today's presentation, we'll have covered a bit of just the basics, what we really need to understand about fibroids. And I think the scope of today's talk is going to basically what are fibroids, and why are we talking about fibroids? What is the significance? What issues do they cause to patients, if at all they do cause any issues to the patient? Is there any reason for us to be concerned if at all we have been diagnosed with fibroids? And if so, what are some of the options of treatment do we have in management of fibroids? So I think that's how I plan to do my talk this evening. And hopefully we're going to have a few minutes at the end of our session that we can just have Q&A and maybe address a few of questions that our attendees might be having. Maybe the host maybe you can give me an okay to share a slide here, if that's okay. Is that possible?
Yes.
Okay. Yeah,
that's okay.
All right. So again, I have the rights of the admin here, so I'll keep muting a few. Okay, so let me see where this presentation is. Share presentation. This would be the presentation. Let me see. Close this. I hope you can. And back. Can you now? Are you able to see my slide?
Yes.
Excellent. Okay. So
Yes.
just quickly, okay, excellent. Thank you. So just quickly, we're just going to have a look at the female reproductive system, basically what it's all about. And so the image here is what we call the female reproductive system. And this will comprise of the uterus. So if you can, I hope you can see my pointer here. So the uterus is going to include, so we have down here, we have the vagina, and then we have the cervix here, and then this is the body uterus. So this is what we consider as the uterus. So the cervix, and it's considered to be part of the uterus, and then this is considered to be the body of the uterus. We have the fallopian tubes, which are lateral to the uterus, and we have the ovaries, which are actually outside the uterus, just between the fallopian tube and the uterus. So the main function, or the main function of the uterus basically is to facilitate conception and housing the product of conception, that would be the fetus or the baby during the growth. So just quickly, what exactly happens for fertilization to happen, and I know this is not the scope of my presentation, but just quickly mention it, is during sexual intercourse, going back here, during sexual intercourse, what basically happen, ejaculation will happen, and then the sperms will swim through the cervix into the uterus. And if it's around the time of ovulation, that is going to be, and I'm happy that you're having menstruation presentation right before this presentation. If it's on the 14th day, ovulation will happen. So an egg is going to be released from the ovary, and then the fallopian tube will now get hold or is going to pick up the egg. We call it the ovum, and then the egg and the sperms will meet inside the fallopian tube. Fertilization will happen, and then thereafter is happily ever after, and fertilization. Then the fertilized egg comes back into the uterus, and then it's going to develop and grow, and baby, and after 9 months, delivery will happen. It sounds that simple, but it's a really complex. It's a really complex process. Now, the uterus, therefore, now when we talk about the uterus is made of muscles, and that's the reason why during menses we say, "Oh, I'm having this cramping pain," and the reason why you're getting this cramping pain is because the muscles tend to contract and expelling the menstrual blood and the rest. Now, so basically that's the basic anatomy that we need to understand, that when we talk about the uterus. Now, then the question we ask ourselves, then therefore, what is a fibroid? Now, again, remember we have said that fibroids, we have said that the uterus is made of many muscles, lots and lots of muscles. And for you who can remember the biology, remember we used to have the skeletal muscle, we used to have the smooth muscles, the cardiac, and so on and so on. So the uterus is made out of smooth muscles. And so what basically fibroids are is you're going to have benign. By benign, we mean is non-cancerous swelling or tumors, whatever you want to call it, that are going to develop from a single smooth muscle of the uterus. So what happens is, just like any other tumor, the growth and development will, you lose the control of growth. Then you'll find that the tumor will keep growing and growing and growing, and that's how we end up getting fibroids. Now, again, remember I've said that the uterus is made out of thousands of smooth muscles, and just only one smooth muscle, when it loses the control of development, then it could start, growing in size and growing in size. And if that happens, then you're going to have a fibroid develop. And then the fibroid will come in different sizes, will come in different shapes. It can be just any part of the uterus. But of importance is that we need to emphasize that fibroids per se are not cancer. And that's usually most of the question we get from patients. Is a fibroid a cancer? Well, the answer to that is not a cancer. So now, this is exactly what we were talking about initially. So we can have fibroids develop on the uterus, and it can just be any part of the uterus. And now if you have the fibroids developing, then they are going to have different names, and the names are going to depends on what part of the uterus this tumor has developed. And also the symptoms of the symptoms that the patient will experience will depend on the location of the uterine fibroid. And that is very important. So I'm sitting in my clinic, a patient shows up and says, "Oh, Dr. Njagi, I'm getting heavy bleeding and I'm having pain. I had an ultrasound scan and this is short." So immediately I kind of have in my mind what kind of, what type of a fibroid or what's location of the fibroid are we talking about. So again, this is what can happen. So you can have a fibroid on the wall of the uterus. Now that is, what we call intramural fibroid. And usually the ones that are on the wall of the uterus, those are not really of a big of a problem per se. So this is, but then again, it depends on the size. So these are the ones that, if a patient is having menses, they'll have a little bit of pain when they are having menses. Now, the ones that are very notorious or the ones that are very symptomatic are the ones that are closer to the inner lining of the uterus. And maybe I should have mentioned this on my first slide, that the uterus has different layers. We have the middle layer, which we have said is made out of muscles. And then we have the inner lining of the uterus, which is the endometrium. And the endometrium is the one that sheds off every month. And I know you heard this talk right before my talk. So when you're having menstrual bleeding or whatever, it's going to be the inner lining of the uterus that kind of sheds off. Now, this is what it means. Therefore, if you have or has a fibroid that is closer to the inner lining of the uterus, then that is a little bit going to be symptomatic. In what sense? The patient are going to bleed a little bit more. Their bleeding is going to be quite heavy. The reason is because the surface area of the endometrium is increased. That's number one. Number two, remember we said that during the menstrual, when you get the menstrual cycle, the menstrual bleeding, you have the cramping pain. What basically the cramping pain means is the uterus is just contracting, and during the contraction is strangulating the vessels that tend to bleed. That's number one. Number two, during the contraction is expelling this endometrium that has been shed off. That's the other thing. So you can have one is close to the lining, or you can have one it is inside the uterus. Now, the one that is inside the uterus, this can be called a pedunculated, or sometimes it might be intracavitary, or some will call it a polyp, whatever the name it's given. Again, this is very, very symptomatic in terms of bleeding, and number two, in terms of pain. Now, you need to remember that. Now, more than that, the fibroids, if they're inside the uterine cavity, can also cause infertility. How do they cause infertility? The reason is because this fibroid might be occupying the uterine cavity. So when the fertilized egg is moved or has been transported back into the uterus, this is what we call implantation, or embedding the fertilized egg on the uterine wall. That might not happen. So you'll have a patient either who is having delayed infertility, patient who will present with heavy bleeding, patient who might present with bleeding during the menses. So you have spotting. Your menses ended last week, but in between the menses, you're getting a little bit of spotting. Then that could suggest that the patient might be having one of these fibroids. Then the ones that are outside the uterus, we call these the pedunculated fibroids, the ones that are hanging outside the uterus. Almost always these are not symptomatic. Even patients are not going to know that they have these fibroids because they don't cause them any problem. They don't cause infertility. Unless the size is, it is really large. And these fibroids can be really, really, really large at some point. So if they are that, if they are big in size, then definitely a patient might have this discomfort, might feel, heaviness or discomfort in their lower abdominal wall. Now, what are some of the causes of fibroid? Maybe that's a big question. And if we know the causes of fibroid, then we must say, okay, fine. If we know the causes of fibroid, then we might prevent the fibroids from actually happening. Now, unfortunately, by far, we don't know the causes of the fibroid. But what we have seen is that we have seen fibroids in family. So let's say, for example, if my mom had fibroids, most likely my sister is going to get fibroids, because then, that is going to be hereditary or is going to be genetic. So genetics, we have seen that patients, who have what we call first degree, or their parents or their sisters or something like that, they had fibroid, the chances of them having fibroid is possibly high. Of course, that's the family history, genetics, and hormones. Why do we say hormones? We say hormones because the fibroids have been found to develop or grow during the reproductive age. By reproductive age, we say these are the age that a woman is fertile, actually from the beginning of their menses, end of their menses. So what we have actually found is that when women reach menopause, the fibroids don't grow in size. If anything, they regress in size. So which is a good thing, which has actually made us to believe that the fibroid growth or development is under the influence of female hormones. And this, mostly the estrogen, which is predominantly a female hormone. And that's also the other reason why we find some of the risk factors. We found oral contraceptive. Using oral contraceptive predisposes the woman from either the growth of fibroids or development of the fibroids, because these oral contraceptives, and I hope you guys have had a talk on this, usually is a combination of female hormones, estrogen and progesterone per se. Other risk factors that we have found is pregnancy usually predisposes to growth of the fibroids, because we know that during pregnancy is a high hormone period during that stage, and we actually see the fibroids tend to grow in size, and some small ones get to develop. Nulliparity, what that nulliparity means is someone who has not who's not bearing children. We have seen also them having fibroids develop, and the reason again, it's the influence of hormones that are generated by the ovary for a duration period of time. So basically that will be some of the risk factors. I have to mention, this is a little bit sad, but I remember when I was in medical school, and we used to ask, okay, what are some of the risk factors for certain conditions? Sometimes you always find ourselves saying, oh well, it's race. If you're race of African origin, you're at a risk factor of certain condition. Unfortunately, yeah, it's more or less true. Fibroids have actually found predominantly that African descent race are at a high risk of getting uterine fibroids. Again, genetics come on board, and if anything, most of our the patient that we get to see, as I mentioned during the beginning of my presentation, is the main presentation is usually uterine fibroids. So we get to see a lot of uterine fibroids, whereas people from developed country or Caucasians, white, there's not much reported cases of fibroids. And if they are fibroids, basically, it's not in so much extent as we see them here. So again, this is what I was talking from my previous slide. We have different fibroids, and these fibroids can just be about anywhere. They have no, they have no limits. You can have them on the cervix, you can have them closer to the inner lining, you can have intracavitary on the wall, just about anywhere. But then again, remember what we've said, the ones which are outside the uterus, the ones which are pedunculated, are usually not going to cause patient lots of problem. The ones that are inside the uterine cavity or closer to the lining of the endometrium or the lining of inside wall of the uterus, those are going to be symptomatic. So now, then again, how does patient get to know they have fibroids? Or if at all patient, fibroids are going to bother the patients, what are going to be the classical symptoms or presentation? Interestingly enough, you find that 75% of the patients who have fibroid remain asymptomatic. What does that therefore mean? Now, I see we have 45 of us here, and I'm assuming that all the 40, well, excluding myself, if the 44 of ladies here today, and we, let's say assume none of the ladies here know that they have fibroids, they have not been diagnosed, they have none of the symptoms that are presented. If it's okay, all of you, let's do an ultrasound scan. You're going to find possibly majority of them, they have they could be having fibroid. But then again, the fibroid can be in different size, which might not be a problem at all. So most of the patients remain asymptomatic. So you're having the fibroid, it doesn't cause you any problem, that's okay. So it doesn't mean that you need to go be investigated, or is a routine screen that you need to be screened for uterine fibroid. Of course, again, that is not necessary whatsoever. Now, if patient then have symptoms, the other 25 that are going to be symptomatic, what is going to be the possible presentation? Most of them are going to present with menstrual abnormalities. And again, presentation on menstruation has been given. So what does therefore mean? Again, remember I have said Patient will present with bleeding, which is called which is, medically we call it menorrhagia, and menorrhagia is basically heavy bleeding. So now, how is this going to present? Now it's going to present either prolonged period. So if your menses, we say, is usually about 3 to 5 days, if you more than 7 days, call it menorrhagia, or if your what we consider about 80 mils of menstrual bleeding, then we say that's a heavy bleeding. Then that will be cause for investigation to actually find what is the cause of the the heavy bleeding. I had mentioned metrorrhagia or irregular bleeding. Metrorrhagia will be bleeding in between the menstrual cycles. So the moment the shedding of has taken place in a normal uterus, bleeding should not happen. Even what we call what we might consider as spotting should basically not happen. So if you're having spotting in between your menses, then possibly this could be a presentation, or it could be an indication that there could be a fibroid patient. Other presentation could be painful menses, having your menses and you're getting this pain. Now, let me pause for a little bit, because when we talk about painful menses, there's a lot of misconception about painful menses. And I would say it just breaks my heart anytime a woman walks into one of our clinics and they're presenting, oh, Dr. Ari, are having painful menses, and then unfortunately we say, oh no, that is okay, painful menses are okay, wait until you either conceive or you deliver, then the menses are going to go out. Again, that is a misconception. It's not a scope for this presentation, but there's something called endometriosis. Endometriosis and painful menses just go hand in hand. And I've been told that there's a presentation that will be done for endometriosis, painful menses. So anytime you're having painful menses, please, it's very, very important to be evaluated. And this is my classical evaluation. If a patient having painful menses, they do an ultrasound scan and there's no intracavitary fibroid, then poof, my diagnosis usually is endometriosis. So painful menses, infertility, and again, we said why infertility comes into play when a patient has uterine fibroid. It's just because the uterine cavity does not give room for the pregnancy to happen. Implantation might not take place. So we could have infertility. But it doesn't mean that a patient who has fibroid cannot conceive and cannot carry pregnancy to term. We have had patients who even have very large fibroids. I had a patient who had twin pregnancy. She had a fibroid which is about 9 centimeters, and she was able to carry this pregnancy to term, even with a 9 centimeter fibroid. Of course, the pregnancy is usually a little bit difficult because the symptoms like pain and so on and so forth. But again, it doesn't mean every patient who has fibroid, they're going to present with infertility. No, that is actually not correct. So it doesn't mean you go and you have an evaluation, you have a 2 centimeter fibroid, and oh my goodness, you're all worried now, you're going to present with infertility. Absolutely, that is not entirely correct. You say low abdominal pain, abdominal swelling, and you find some of the fibroids are so large, and patient will come to us and I'm like, oh my goodness, you want to tell me that for all this time you did not realize that your abdomen is so large, there was something going, and funny enough and innocent, they say, no, I thought it was normal, I thought it was fine. But then when you examine them, you actually find that they have mass growing in there, and ultimately it's a fibroid. Pressure symptoms, this is going to depend on the size of the fibroids. So again, how do we make diagnosis? How we make diagnosis when a patient presents to us? So when you come to our clinic, what we do, we listen to your story. You will tell us, hey, this is what's going on. I have been having bleeding, or I have been having difficulty conceiving, and so on and so forth. And if we are suspecting the fibroid, then we'll examine, whereby we'll examine your abdomen, and what we call palpation. We're going to palpate your abdomen. We want to feel the uterus. Basically, on a normal uterus, you're not supposed to feel it because it falls down what you call in the pelvis. But if you can actually appreciate the uterus, that means it feels firm. It's not evenly distributed. It has bumps. Then that could suggest that the patient has fibroid. But then to confirm, you send a patient to do an ultrasound scan, and an ultrasound scan is a test that you will go to a sonographer. They're going to put a probe on an anterior abdominal wall, and then they're going to have a look and evaluate the uterus, and then they can be able to identify if there are fibroids and more so how many of the fibroids, the sizes of the fibroids, and so on and so forth. MRI, it's again another investigation, CT scan and so forth and so forth. But the very basic modality of investigation would be ultrasound scan, which is again quite affordable. Again, viewers' discretion here. I'm sorry if this is going to disgust any one of you. My sincere apologies. But then again, this is how basically fibroids will look like. And I wish I had a normal uterus, image. So basically, again, we said you can have 1, 2, 3, 4, 5, 6, and so many fibroids. They can be as many as 100 of fibroids. And now you see they completely distort the uterine cavity. You can see this is a fibroid, 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 this is a fibroid. Quite many fibroids. And then you also find maybe deeper on the wall of the uterus. You can even have more fibroids. So definitely, this patient is going to present with bleeding. They're going to present with heavy bleeding. They're going to present with abdominal pain. They are going to present with distension of the abdominal pain, pressure symptoms, and possibly infertility. So again, after we do the surgery, this is the number of fibroids that were removed. I don't remember. I don't think we ever counted this. And then you can see how small the uterus now gets after it's been operated. Again, I really apologize if by any chance this, not, good image for any one of you. So now, again, I said fibroid can come in different sizes. It can be as big as a watermelon, and they can come in different numbers. I would say this is the image on the lower right corner. These have been my most fibroids that I've ever removed. This is an open surgery. I think this was 78 fibroids. This was 78 fibroids. These were 56 fibroids. And again, you can see they come in different sizes. Now, what I think it's important for us to understand, this one, which I think is one of the biggest in size, at one time it was this small. So you are not born with fibroids. So it starts with a very tiny fiber. Then over time, under the influence of hormone, they keep developing and growing in size. And, sometimes it's one, sometimes there are two, sometimes there are quite many. Now, this is what it means therefore. And I think there's a question that I've been asked. Why do we have, fibroids recurring? This is the reason why. Because we don't know where they came from in the first place. This is what I'll patient come and tell, oh, doctor, if you remove my fibroids, there are chances they are going to recur. And this is what I tell them. If I have 100 patients, and all these patients, all of them, they have one fibroid, then I have another group of 100 patients that have, let's say, 20 fibroids. And all these two groups, I get rid of their fibroids. Which group do you think they're going to have, fibroids recurring? And almost always my patient get it right. The one with many fibroids, they are going to have fibroids recurring, because remember again, we say that this fibroid would develop from one smooth muscle, and this is microscopic. You cannot even see it with your naked eyes. So therefore, if your patient is having many fibroids, that means they have a higher tendency of these muscle cells, they have lost the control of development, and under the influence of hormone, they keep growing in size, and then the chances they are going to recur for obvious reasons. But if a patient has one fibroid, we remove it, we find that their tendency of recurrence is much lower. Of course, now in terms of let me see, sorry. So finally, I'll talk about treatment. And there are different types of, modalities of treatment. And I think I will just give different types of treatment, and patient preference again, and whichever doctor preference will have, I think makes a huge difference. Now, when we talk about treatment, we can talk of medical treatment, we can talk of, non-medical, of medical treatment, and of course, surgical treatment of uterine fibroids. So let me start with medical treatment. So medical treatment, remember, again, and this is where I think most of us mislead patients, and I'm sorry if that has happened to any one of us, whereby you go to someone and say, oh, we give you certain medication, and when we give this medication, these fibroids are going to disappear. That is absolutely not true. So let's say, for example, you're bleeding and you come to my clinic. I give you, for example, the commonest medication we give is ranferon, which is going to boost your blood. We'll give you tranexamic acid to help with the clotting of the blood. We give you hormone medication like Primolute or Dufastone and so on and so forth. Now, that only takes care of the symptoms, which is bleeding. But for the most part, they do nothing to the growing uterine fibroid. Let me repeat this again. When you're given, let's say, tranexamic acid, ranferon, saffron, pain medication, Primolute, Dufastone, and name them, and so on and so forth, those medications don't do nothing to the fibroid. Again, some will get contraceptives. Again, we've seen that contraceptives are risk factors for development and growth of the uterine fibroid. So what basically we say is that medical treatment does not have much role in management of uterine fibroid. There are going to be other medications which are going to be rather slightly expensive, and maybe some of you have had medication like Zoladex. You've had medication like Leuprolide, that, oh, we're going to inject you with Leuprolide. Once you inject you with Leuprolide, your menses are going to disappear. We are going to put you on medical menopause. And when you put you on medical menopause, magically, poof, your fibroid disappears. Again, that's another misconception. The reason why we put patient on Leuprolide is to cut the hormonal supply. And by that, we think, or we feel that the fibroid growth is going to be halted. It's like a patient who has gotten to menopause, but again, we cannot put patient on this medication for too long. So for example, if you're on Leuprolide, the maximum we can put the patient on Leuprolide is going to be a period of 6 months. So exactly what happens after 6 months? Menses come back, and then you're going to still have the hormone, and then the fibroid, if it had been held captive, is not developing, then after that is going to develop. Some will be told, oh, your fibroids are large, we cannot operate, let's first shrink them. Once we shrink them, then we can operate, we give you an injection. Again, that I would say is from physician to physician preference. So again, as I mentioned, we have found there's not much role of medical treatment in the management of uterine fibroid. Therefore, what would be the ideal or the recommended treatment of uterine fibroid? And for that, I say surgery remains the main option of treatment for uterine fibroid. So in terms of surgery, therefore, what does that mean? Then it means that you're going to have a surgery either called myomectomy. Myomectomy would be removal of the fibroids and preserve the uterus. So, and what I was just showing here, this patient underwent myomectomy. So again, you make an incision here, you remove the fibroid, you make an incision here, you remove the fibroid, and then you stitch it back. You can see this has been stitched back. So then you're going to preserve the uterus. And this is going to be for patients who are who have fertility desire, or they want to have children. Then it's paramount for us to preserve the uterus. So myomectomy will remain as the option of treatment. The other option of treatment, let's say, for example, a patient come to us, she's about 44 years old, and she's having this fibroid that are just really messing her up. And she said, you can find Dr. Ari, I've had, 4 children, and I think I'm done. My last born is about, 15 years, and I'm not looking forward to getting another child. Then you say, okay, fine, no problem. If fertility is not a future plan, and you feel that you have completed family size, then removal of the uterus could be an option of choice. And then, so what that means is we remove the uterus. When we remove the uterus together with the fibroids, everything comes out. Bleeding, bye-bye. Menses, goodbye. There's not be recurrence of fibroids, and the patient will live happily thereafter. Having said that, let me also say the following. On occasion, you'll go to maybe Dr. Njagi, and let's say you're 35 years old, and then you do an ultrasound scan, and let's say your uterus is at the level of your kitovu or your umbilicus, and they'll say, oh, your fibroids are really large, we cannot do myomectomy, we can only remove the uterus. Again, that is a myth. That is absolutely no. Again, as I've shown you, we can remove up to 70 fibroids. It depends on the doctor's or your surgeon's skill. But if the patient's preference is to preserve the uterus at any cost, that should and must be respected at any cost. I have a patient who comes to me today. Patient is 35 years old. She has about 3 or 4 fibroids. She has gone to a gynecologist. Gynecologist said, oh no, we need to have the uterus removed. I'm like, you better be kidding me. How can you remove a uterus for 35 years old? She has so many years of fertility. Why don't you have, preserve the uterus? So again, the decision either to remove the uterus is only and only should be made not by your physician. The decision should be given, and the power of making the decision should be at any given time be reserved to the patient. So what do we need to do? We only need to give you information, and that you will make informed consent. I understand that I have this option. I understand I have this option. I understand I have this option. Even for those who say, okay, no, I first want to try medical treatment. Surgery sounds quite invasive. And we say, okay, fine, that's not a problem. Let's try medical treatment. If it doesn't work, that, so the patient gets to decide. We don't get to decide option of treatment. You get to decide the option, but we are mandated at every given point to give you all the information, as much information as possible, to help you make a decision. Now, in terms of surgery, there's a tradition open surgery whereby an incision is either made below the at the level of your abdomen, which is called the bikini, which is really nice, or the ones that you get during cesarean section, or sometimes you can get, sometimes this is not very pretty incision, depending on how large the uterus is, and this either for removal of the uterus or removal of the fibroid. These are incision that we make. But traditionally, currently we have what we call laparoscopy. Laparoscopy would be small incision. Again, those would be the options. Then again, it's very important for you to have a discussion with your physician. You need to see what does you and what and it's going to depend on your physician. Again, the question is, are there chances that we could have this fibroid recurring? Possibly, yes. Again, what are going to be some of the factors that are going to predispose the recurrence of uterine fibroid? Again, there is factors that we talk about, the number of uterine fibroid, the age of the uterine fibroid. This can predispose to the recurrence of uterine fibroid. Is there anything else that I've left behind in terms of uterine fibroid? No, I really don't think so. So I think that's just a brief view on fibroids. Unless there's any question, again, I'm very grateful to be part of this team tonight. So yeah, again, maybe quickly, again, viewers' discretion advised here. This is how we do open surgery, laparoscopy, and maybe this could give us a better view of how our uterus looks like, or how we could perform myomectomy. This is again is laparoscopy, and sorry. So it's important if you can be able to see this video. Sorry, yeah, let me show you guys this. So when we do laparoscopy or hysteroscopy, laparoscopy means we are putting a camera inside your abdomen. Hysteroscopy means we are putting a camera inside the uterus, and this is a camera that is inside the uterus, and you see this huge swelling here. This is a fibroid that is inside the uterus. Now, if you have this, and this is a large fibroid, if you have this type of a fibroid here, that would mean the patient is going to present with bleeding, and of course, this is a patient who are going to present with possible infertility and or pregnancy losses. They get pregnant, but then they lose the pregnancy, and of course, heavy bleeding and more so pain. So anytime we do laparoscopy, we have to check inside the uterus, and then you really can find this. Now, this can be and again, there's another fibroid here. So sometimes they can be 1 or 2. Sometimes inside the abdomen, inside the uterus, they can be quite a number. And when we do laparoscopy, then we put a camera inside the abdomen, and we are able to have a look at the uterus. This is the image that I was showing, fallopian tube. This is the uterus, and you can see the uterus is quite large here because of the fibroid. Because of your discretion, I plan to not proceed because it's going to get a little bit bloody. But should you be interested, there's a link up there that you can watch this on on YouTube, and get to understand how we this can be done laparoscopically. Other than that, thank you so much. I'm ready to take any question that could the team could be having. Thank you.
Hello, thank you so much, Dr. for such an insightful session. I really appreciate, and on my side, I took something that was so important, that it's our choice when we get fibroids, that we should, if we opt for myectomy, we go for myectomy. Honestly, most doctors, most gynaes, they prefer you just get the fibroids removed if it's so large. I remember an argument with a woman who was told to remove the uterus because it is too large and she can't bear. I don't know. I didn't understand anyway. So actually, thank you so much. We have some questions, so I'll just read them out. Teresa is asking, how is pregnancy and childbirth a risk factor to fibroids?
Okay, how is childbirth and pregnancy? Again, remember I said that during pregnancy, the woman is, it's a high, what we call the high estrogenic state. So the hormone estrogen is at a very, very high during pregnancy. That is definite. And again, remember what we say that the fibroid only developed during that, fertility age. So what we know for a fact is that development of uterine fibroid is under the influence of estrogen. So if you have a patient, therefore, that is pregnant, and this is true, what we find is that if you have let's say you follow a woman and then she's not pregnant and you're doing serial ultrasound scan, You do the scan today, and then you do a scan after 2 months, and you see, okay, the uterine fibroid was, let's say, 3 centimeters, and then after 3 months, it was 4 centimeters. And then the same patient gets pregnant, and you do an ultrasound scan, and you see, okay, from 4 centimeters, 3 months, it possibly could have doubled. And the reason to that is, number one, is that the woman is under the influence of hormones. So that's the only reason why we say that pregnancy and childbearing, childbearing age is because of the influence of the hormone. Again, that would be the explanation for that. Also, what we find once these women have delivered, during the period whereby they are breastfeeding, usually there's not much influence of hormone. The hormone has been cut off. We find that as the uterus goes back to normal size, also the fibroids tend to shrink up to a certain point, and then this can keep growing with time. So that's the scientific backing up of that statement. I hope that answered the question.
Teresa, I hope you answered. Yeah, she's answered. So we have another question from Ross Achala. Yeah, I think you answered that question on treatment on fibroids. What causes, I think it's ectopic pregnancy, and what is the remedy?
Okay, sorry, let me unmute. Sorry. Ectopic pregnancy, another interesting question there. See, remember what I said, that during conception, this is exactly what happened. And I hope you see how that picture in your mind. During sexual intercourse, ejaculation in the cervix, the sperms have a tail, so they are able to swim through the cervix into the uterus and both fallopian tube. Ovulation has happened on the ovary. The fallopian tube will pick up the ovulated ovum or egg, and then that in the fallopian tube fertilization happens. Now, this is what ectopic means. Ectopic means is a pregnancy that is outside the uterine cavity. That's number one. And if it's an ectopic pregnancy, it can be either on the fallopian tube, any part of the fallopian tube. It can actually even be outside the fallopian tube. And that's what we call an abdominal ectopic pregnancy. But majority of ectopic pregnancy will happen in the fallopian tube. Now, why does it happen? Sometimes we don't know, but this is what is believed. How the egg therefore moves. Remember, we say the sperms can swim, but the egg does not have a tail, so it cannot swim. So how it does, it's usually the movement of the fertilized egg is facilitated by the fallopian tube itself. So it contracts, what you call peristalsis. It's like when you eat your food, you never tell your food, okay, fine, now move to the stomach, okay, move to the large bowel, or move. You don't have control of it. So automatically, because of the smooth muscles, that you really don't have control of your smooth muscles, as you have your, this is what we call the skeletal muscle, it moves involuntarily. So it's going to contract and then move. The second thing is that there are small finger-like projection inside the fallopian tube that beat in a waveform, and this facilitates the transportation of the fertilized egg from the fallopian tube into the uterus. For any reason, this mechanism can be defective. If it's defective, that means this fertilized egg will not be moved into the uterus. And it doesn't matter where it is, it will continue growing. So if it's on the fallopian tube, the division is happening, division from 4 to 8 to 16 to 32 and so on and so forth. And then it keeps developing. If it develops and I think is second or whatever day has not reached the uterine cavity, that would be an ectopic pregnancy. Some of the causes that could be infection, previous surgery to the fallopian tube. For those who have had attempts to open the fallopian tube, which is called tuboplasty, could really affect the integrity of the fallopian tube. But the commonest cause that we find is usually PID, and it's very common lately. And this is the same thing that is leading to blocked fallopian tube. We have seen the IVF rates have gone very high. It's, it's a long, story. Management of fallopian tube ectopic, again, I would say that would be another talk. It depends on the size. It can be medical treatment, it can be surgery. And surgery, they are different, where you preserve the fallopian tube or you remove the fallopian tube. But in most cases, if you have a tube of ectopic pregnancy, what we do is removal of that fallopian tube together with the pregnancy, which is called salpingectomy. But not to worry, you still have one fallopian tube, so you can still get pregnant.
Thank you. Rose, I think, and Therese, I think we answered, and yeah, we have had
Yes,
some.
you have answered. Thank you.
So we have another question from Veronica. If you're on family planning and your menses stops and you only receive spotting almost daily, can it be related to fibroids?
So, well, again, as much as I say that spotting is it can be as a result of uterine fibroid, it does not necessarily mean every patient who has spotting is because of uterine fibroid. Let me correct that statement. So let's say a patient comes and say, I have spotting. So this is what we call possible diagnosis, or medically we call it differential diagnosis. So if a patient comes with spotting, what could it be? It can be fibroid, it can be what's called as hormonal imbalance, it can be pregnancy, it can be, sometimes when using family planning, there's what we call withdrawal bleeding. So we have to, and the way to figure out this is only by doing an ultrasound scan. So if you're taking you more or less you're starting family planning, especially the implant, the implant are very notorious in causing spotting, because these are, we call them, they are progesterone only contraceptives, and these leads to thinning or thinning of the inner lining of the uterus. You can get patient presenting with spotting. So the answer is no. If you're using contraceptives and you're spotting, it does not necessarily mean that you have fibroid. Spotting can mean anything. So it's important for you to see your physician, tell them how is this happening, when did it happen. They'll ask you, when was your last normal menstrual period. Maybe possibly you could be pregnant even when you're using contraceptives. You can get failed contraception. So it could just be anything. So it does not necessarily mean they are fibroids, but yeah, it can still be fibroid. So it's important, if you're having spotting and you're not happy about it, please see your physician, have a discussion with them. The least they will do is send you for an ultrasound scan. And if the ultrasound scan says there's no uterine fibroid, then we need to think, could this be hormonal related spotting, either as a result of the contraceptive, withdrawal bleeding, or so on and so forth.
Thank you so much. I think, Veronica, I've got that. It is not a must that spotting can be due to fibroids. They can be maybe failed contraceptions, or you can be pregnant. Okay, thank you. We have another question from Rose. What causes barren women look like they are expectant, they have a big tummy, then all of a sudden it disappears?
Wow, that's an interesting one. Let me say this. medically, you're either pregnant or you're not pregnant. So the whole say that, oh, you look pregnant, you can look pregnant, but you're not pregnant. You can look pregnant, and yes, you're pregnant. I would say we never ever make the diagnosis of pregnancy by looking at a patient. So the first thing that a patient gets to know they are pregnant is they have been having normal menstrual cycle, and then over a period of time they have missed their menstrual cycle. So the first thing we have to confirm is, are they pregnant or they're not pregnant? The patient who, let's say, for example, they have fibroids. Remember, again, we said, their lower tummy will be, will be enlarged. So sometimes that can be a misconception. Oh, they think is a pregnancy, and it's just a large, uterus. That is not necessarily a pregnancy. It's basically fibroids. So, but then again, that cannot be missed out because this is something that goes for quite a while. The commonest, and this we find a lot, is where we have something we call pseudo pregnancy. Pseudo pregnancy is a strong belief that a woman says, I am pregnant, and they are not pregnant. So these are patients, for example, who are very anxious. They have been trying to conceive for a very long time. They have been diagnosed with infertility, and for some reason, they have this symptom that they relate them to being pregnant. So it can be breast tenderness. They could feel they are bloated, and they relate that to being pregnant. We call that pseudo pregnancy. It's just a misconception or a strong belief that they could be pregnant. How do you get to know you're pregnant? Simple. Something that we all know, and that is performing a pregnancy detection test. That tells you you're pregnant or you're not pregnant. So scientifically, there's really nothing that can just show you're pregnant when you're not pregnant. Any other question? It looks like our host disappeared. Okay, no, she's there. All right. Maybe I can just read through. Well, yeah, you guys are welcome. I think the pleasure is mine being here. So there's thank you notes I see here. The pleasure is all mine. It gives me a lot of pleasure to talk about something that is very dear to my heart. Nyaboke say, I read that higher level of estrogen hormone instigate the growth of fibroids. Again, correct. And this is what I've been saying, pregnancy and so on. Use of contraceptives will be, high estrogenic levels. Your contact, please, for more clarification. Okay. To what extent do people prefer laparoscopic myomectomy, or can we say people are aware of it? Just to answer the question about laparoscopy, very few, it's a skill. And this skill is very few, I would say few gynecologists have it. And laparoscopic myomectomy is considered to be one of, difficult surgeries. So please have a discussion with your gynecologist. Let them, ask them if laparoscopic myomectomy is an option. By them saying no, it's not an option, it doesn't mean that it cannot be done. Just because someone cannot do it doesn't mean that it cannot be done. Yes, laparoscopic myomectomy is a possible solution, option of treatment. And again, as I tell my patient, please seek a second and third opinion. You are entitled to as much information as possible before you can make a decision. Thank you, James Ngeshu. Thank you for the information session. Could you expand on the issue about blighted ovum? Again, because of time, James, blighted ovum, what means the pregnancy took place, but either the DNA, which is what really turns to a baby, did not happen. So it's not a real pregnancy person. Pregnancy has happened, but the real content that forms a baby did not happen. If this happens, then this need to be removed, and it doesn't mean that it's going to recur. just something that was not right just happened. Pelvic inflammatory disease, again, I would request the organizer maybe to plan a session on this. It's a long one. It's something that is very common. We are seeing it a lot. And PID is commonly causing fallopian tube blockage. And that's what is leading to a lot of IVF, because, causes infertility. Can implantation fail and why? Yes, implantation can fail. Even when the egg has, even during IVF, you've had patients who have gone IVF, fertilization has happened, the embryo has been transferred to the uterus, but then pregnancy, it doesn't have transposited. That means implantation can fail. There are many reasons. Either you have defective inner lining of the uterus, which is the endometrium. You can have chronic infection, TB, and so on and so forth. Maybe so these are some of the things that can lead to implantation failure. Thank you for your response. I think those were the questions that I've been able to skim through, and I think for me it's just to my contact. Okay, so I'm just writing it here. So again, I've sent my contact. I just want to let you know, guys, that phone calls sometimes is very difficult. I'm mostly in operating theater. Anything that we can do to help, please, send me a WhatsApp message. It might take me some, few hours to get back to you. But at my earliest convenience, I'll be able to respond to you. Usually we try as much as possible, just to be honest, unless it's something that is very urgent, discouraging, consultation, because again, when we do consultation over the phone, there are a few things that we miss out. I have patients, asking me a few questions on the phone because this is their interpretation of their symptoms. Then I ask them, can you come to my office? Then we get to see you. Then when they come to the office, it's a totally different story. Then we get an opportunity to examine. So if you're asking me a question on WhatsApp and I feel like I'm being resistant to, to answer the question, just know that it's important for us to have a conversation and have an examination. The second number that I've sent, it's usually for my clinic. In case you ever want to come and visit us, please, the second number, you'll be able to talk to someone who will be able to help you. Where am I stationed? I'm in Kirinyaga County, town called Kerugoya. And I'm also in Nyeri County, a hospital called PCA Tumutumu in Karatina. That's where I'm based. Nairobi, do I come to, maybe the next question, do I come to Nairobi? No, mimi msee wa mashinani. I look after the folks out here. Kuna magaina wengi sana Nairobi, so tutakuwa wengi. So sisi wengine wetu tume decide to stay huku mashinani. All right. Well, I think thank you so much, everyone, and I wish you a lovely evening, and I wish you good health. Please take care of your health, and the best investment you can ever do to yourself is invest on your health. Purely, I would say that's the best thing that you can do to yourself. So thank you so much, everyone, and I'm very grateful for this opportunity once again.
Thank you so much, Dr. for such an insightful session. Honestly, I'm so glad I've learned, and yeah, I'll keep learning. And honestly, I can see from the participants, they are really appreciating such an awesome session. Maybe Dr. you didn't tell them that you're the founder of laparoscopy Mashinani, so that they may be following some of your insights.
Oh, well, I mean, again, look here, I thought I was only supposed to talk about fibroids today. Anyway, yes, let me say just quickly, and I promise I'm going to take 2.5 minutes. Laparoscopy. I feel every woman should be entitled to good quality healthcare. I know our healthcare in this country is quite defective, but that's not an excuse. So laparoscopy, what are the advantages of laparoscopy as compared to open? Well, maybe let me do this. I will just that's my YouTube, well, Dr. John Jag. If you just, search Dr. John Jag, you see my YouTube and you see some of the things, the difference between open surgery, laparoscopy, fibroids, endometriosis, and so on and so forth. So yeah, the reason why we started laparoscopy mashinani was because we needed to bring laparoscopy to common mwananchi, which is, I think it's me and you and everybody else. Because the reason was laparoscopy was only available in a Nairobi hospital, Aga Khan, and it was crazy expensive. And what had actually happened is that the surgeons who were actually performing laparoscopy surgery, they really monopolized this. So that means mimi msee wa mashinani, my wife, my mom, or whatever, they could not, because it was crazy expensive. And then the question was, why is it that these surgeries cannot actually be accessible to the common mwananchi? The only reason was because nobody was training, and I would say people were not willing to give the skill. So we started, and training, and we've been training, and our aim has always been to bring minimally invasive surgery to the rural community. And laparoscopy mashinani was born, and we've been doing this for a few years now. And I would tell you, at least now we can have a conversation whereby, okay, well, laparoscopy, I don't know how to get it from Aga Khan. I can go to Kirinyaga, I can get possibly even better services than I can get from Nairobi Hospital. Maybe the only thing that Nairobi Hospital will provide is, just a comfortable bed and a private room and so on and so forth. But in terms of surgery, we're trying to do that. So yeah, I'm the founder of laparoscopy mashinani. But then again, it's an entitlement to, access quality healthcare. Did that answer the question?
Yes, thank you so much. I'm so glad, and I really wanted the participants to know what you do, and maybe if they have questions, they know where to learn more about laparoscopy. Honestly, I didn't know what was that. But yeah, I'll follow the YouTube channel and learn more. Thank you so much. And thank you so much, participants, for attending. Looking forward to learning more from you, Dr. And I think for that, we can end the session.
All right, it's a pleasure. Next time, I'll be more than happy to join again, and more so to learn from, other presenters. We can all learn together and grow together. So it's a pleasure for me.
Pleasure too. Thank you so much, and I feel blessed. And from our team, thank you so much. Honestly, we'll have other sessions, maybe from the participants. We can have maybe head-up sessions or maybe things like PID, and I'm sure we'll learn more. So with that, everyone, maybe we can have parting shot from our speaker, then we end the session from there.
Was that me or the previous speaker?
No, I was the previous speaker, so we love the parting shots from you.
Oh, okay. Fine. My parting shot here is, oh my goodness. Give me 1 second. Oh goodness. Just 1 second. I didn't know. It's a verse in the Bible. Yeah, my parting shot to you guys is found from the 3rd book of John, chapter 1, verses 2, which says, "Dear friends, I pray that you may enjoy good health and that all may go well with you, even as your soul is getting along well." And that's my wish for all of you.
Amen, amen, amen. Thank you so much. I think with that, we can end the session, and really appreciate your time for sacrificing to let us get knowledge. And we are sure we'll invite you for more sessions, and also you may join our other sessions on our building healthy mother and child training sessions. We have 29 sessions to go. Yeah.
Sure. It's a pleasure.
Yeah, welcome so much. And everyone, have a good evening. Looking forward to see you in our next session on family planning on Thursday.
All right. Have a good night, everyone. Thank you. Bye-bye.
Bye.